Welcome to the Seva Crash Course. This is an introduction to the training program we call Standardized Education for Ventilatory Assistance, developed over the last 15 years at Cleveland Clinic. The whole Seva program offers over 30 hours of self-study and instructor-led training. This crash course is only about 1 hour, so my motivation is to encourage your interest in taking the whole program.
This is my declaration of the conflict of interest.
Before we get into the crash course content, I want to give you a brief description of the Seva program itself.
Seva stands for Standardized Education for Ventilatory Assistance. Seva is also a Sanskrit word meaning selfless service. This education program is a progressive college-level series of courses. The vision of this program is to provide a platform for unifying the concepts of physics, physiology, and technology of mechanical ventilation. Seva will provide a globally available program supported by peer-reviewed articles to help healthcare professionals master the skills of mechanical ventilatory support. The mission is to provide a standardized education program using both online and in-person simulation-based instruction that has both self-directed and instructor-led components. Seva has been developed over the last 10 years at Cleveland Clinic to promote better understanding and use of complex technology. Ventilators have evolved rapidly over the last 4 decades, and conventional education resources have not kept pace. When caregivers have inadequate training, they fail to use advanced ventilator technology to its fullest extent. Furthermore, Seva teaches both a standardized vocabulary and a taxonomy or classification system for modes of ventilation. This establishes the foundation for better communication at the bedside and in the electronic medical record. We believe that better use of ventilation technology will lead to better patient outcomes by shortening the duration of ventilation and decreasing the risk of adverse events.
The first generation of popular mechanical ventilators before 1980 were mostly non-invasive devices like the iron lung, whose success was driven by the polio epidemic. Around the time of the creation of intensive care units in the United States, a second generation of commercially popular ventilators arose that offered only 1 or 2 modes of ventilation. This was true both in the adult and pediatric ICUs. As microprocessors became available in the 1980s, digitally controlled ventilators appeared that had a variety of modes in the third generation. Inexpensive digital displays led to the 4th generation ventilators with integrated graphic displays. The 5th generation gave us ventilators with multiple microprocessors and virtual instrument interfaces. Currently, the 6th generation of ventilators provide as many as 75 different modes on a single device, with advanced control, monitoring, and graphics capability, including use of artificial intelligence, esophageal pressure manometry, and volumetric capnography. In the last 40 years, the technological complexity of mechanical ventilation has grown exponentially. Unfortunately, the educational resources developed to teach mechanical ventilation have not kept pace. As a result, there's a growing knowledge gap on the part of clinicians charged with managing mechanical ventilation. This gap greatly affects patient safety, healthcare costs, and clinician confidence. The rapid proliferation of modes of ventilation has outstripped our ability to classify them. These names have proliferated over the last 30 years or so, but keeping track of what they mean is practically impossible. In the newest respiratory care equipment book by Volsko et al., there are almost 500 different names for nearly 50 unique modes of 36 ventilators. And the number of modes is increasing, with as many as 75 different modes for a single ventilator. The only practical way to deal with this level of complexity is to create a classification system. Systems of classification are called taxonomies. Research published by our group at Cleveland Clinic has established a taxonomy for modes of ventilation. The taxonomy is fully described in the textbook shown in this slide, and is also freely available as a phone app for Android and iPhone called the Ventilator Mode Map. Seva was conceived and developed by Dr. Eduardo Morales Capodevila and Professor Robert Chatburn at Cleveland Clinic, although many other physicians and respiratory therapists have contributed over the last decade. The basic components of Seva have been under development since 1995. The taxonomy of modes of ventilation was the subject of a master's thesis and subsequently published in Respiratory Care Journal. Another key paper in that journal described for the first time a rational framework for selecting modes based on their technical ability to serve the goals of ventilation. The fundamental concepts of Seva have been adopted without modification by nearly every textbook on mechanical ventilation and general respiratory care. The Seva program is comprised of 6 progressive levels of courses and 1 ongoing support activity. The curriculum courses are grouped into intro, advanced, and master levels. Seva Vent Rounds is a weekly online analysis of actual ventilator screenshots to demonstrate the basic concepts of Seva, focusing on graphic waveform analysis to determine patient-ventilator interactions. This slide shows the major topics covered in each Seva course. Note that these topics integrate vocabulary, taxonomy, physics, physiology, and clinical decision-making. We believe that there is no other course available in a university, professional association, or commercial venue that is this comprehensive. Seva Basic is a short, self-directed online course that introduces the main concepts from subsequent courses. There is a post-test with a passing score of 80% that is required to go on to the next course. At Cleveland Clinic, this course is required for all respiratory therapists who work in the ICUs.
Seva Basic gives simplified descriptions of basic concepts like the equation of motion. This course also explains key terms. Seva Basic reviews the taxonomy of modes, which is a classification system similar to the system used in pharmacology for creating generic names for drugs.
Seva Theory is an advanced course on the vocabulary and physics required to understand the mode taxonomy. A version of this course is currently taught online at Youngstown State University in the master's level respiratory care program. There is a pre-test and a post-test with a passing score of 80% that is required to go on to the next course. At Cleveland Clinic, this course is required of physicians in the Pulmonary and Critical Care Fellowship Program.
The second is elastance, defined as the ratio of pressure change to volume change. Compliance, defined as the reciprocal of elastance, is often used instead of elastance. You need to memorize the simple equations for resistance, elastance, and compliance. Note that this model can take several forms. It can be graphical, like the drawing in this slide. It can be physical, like an actual tube attached to an elastic container, the classic straw and balloon model. Or it can be mathematical, that is, expressed in terms of pressure, volume, and flow as functions of time.
The first 3 courses in the Seva program are available free online through the Cleveland Clinic's learning management system called MyLearning. This is an example of what the Seva Theory dashboard looks like. Seva Lab is a unique experience for the learner. It is based on a software patient ventilator simulator that runs in Microsoft Excel on any computer. Learners use a laboratory-style notebook to predict the effects of changes in ventilator settings or lung mechanics on ventilator waveforms. The predictions are then tested using the simulator. There's a post-test with a passing score of 80% that is required to go on to the next course. At Cleveland Clinic, this course is required of physicians in the Pulmonary and Critical Care Fellowship Program. This is the interface for the patient ventilator simulator used in the Seva Lab course. On the left are navigation buttons that allow selection of modes along with a glossary of terms and a wealth of additional educational resources. On the right, we see how lung mechanics and ventilator settings are adjusted and their effects on ventilator waveforms. The simulator is unique in that it also shows the waveform distortion effects of inspiratory effort. This training is a valuable foundation for the later courses in which actual ventilator screenshots are analyzed. Seva Team is a unique team-based learning experience. There are also 4 short videos that are required viewing prior to the course. This course reviews the material in Seva theory and then shows the application to patient assessment and mode selection. It also applies what the student learned in the previous courses to advanced ventilator graphics interpretation and patient ventilator synchrony analysis. At Cleveland Clinic, this course is required of physicians in the Pulmonary and Critical Care Fellowship Program. This is an example of what the Seva Team Handbook looks like. On the left is a brief overview of the discussion topic. On the right is space to record individual and team answers to exercise questions.
Seva Team provides the concepts for applying theory in clinical practice. It introduces the idea that there are only 3 goals of mechanical ventilation: safety, comfort, and liberation. Once the goal has been identified, the appropriate mode is selected based on its technological capabilities to serve that goal.
This is what a Seva Team session looks like when conducted in person. Groups of 3 to 5 clinicians make up the teams. Active discussion of exercise questions makes this a fun and engaging event. Seva Team can also be conducted online, which we did during the COVID pandemic. Seva Sim takes place at a simulation center and uses standard mannequins as well as state-of-the-art breathing simulators. There are also 3 short videos that are required viewing prior to the class. The course provides 3 clinical scenarios to teach the skills of ventilating patients recovering from anesthesia with severe obstructive disease and with severe restrictive disease. At Cleveland Clinic, this course is required of physicians in the Pulmonary and Critical Care Fellowship Program.
Seva Sim teaches 3 common clinical scenarios with hands-on ventilator management. The 3 scenarios are awakening from anesthesia, ARDS management, and optimal setting for obstructive lung diseases.
Seva Sim takes place at a simulation center where ICU beds and mannequins can be used for realistic clinical scenarios. Seva Master is the final course that brings learners to the mastery level by training them on specialized procedures in a simulation center environment. These procedures include monitoring with esophageal pressure catheters and volumetric capnography. The course also teaches the skills to evaluate and treat workup breathing issues as well as weaning procedures. Advanced modes such as NAVA, PAV, and ASV are also demonstrated. At Cleveland Clinic, this course is required of physicians in the Pulmonary and Critical Care Fellowship Program.
Seva Master teaches the practical application of esophageal monitoring using either a standard patient monitor for blood pressure adapted for esophageal pressure or specialized ventilator capabilities. Seva Master also teaches volumetric capnography using either standalone monitors or specially equipped ventilators. The Master course also covers the recruitment maneuvers and the use of pressure volume curves to determine optimal settings for tidal volume and PEEP.
Each course in the Seva program is associated with continuing education units. Currently, these are awarded only to Cleveland Clinic employees. The Seva education program has led to two major spin-off projects. Now we begin the curriculum of the Seva Crash Course. Seva training is required for all RTs working in the ICUs at Cleveland Clinic and for all pulmonary and critical care fellows. As I mentioned before, this crash course is a greatly simplified version of that training. In particular, it stresses the importance of the equation of motion for the respiratory system, the taxonomy of ventilator modes, how to choose the right mode at the right time, and how to interpret ventilator waveforms.
Let's begin with the equation of motion for the respiratory system. To gain a better understanding of these terms, we need a model of the respiratory system. A model is a system of components that in some way represents and usually simplifies understanding of another more complicated system. In this case, we need to represent the complicated system of the airways and lung units with something that is much simpler and easier to understand. The most common model for this purpose is what is called a single compartment model of the respiratory system. It is called a single compartment model because it is comprised of a single flow conducting tube representing the airways and a single elastic compartment representing the lungs and the chest wall. The utility of this model is that we can make measurements of only three variables, pressure, volume, and flow, and use them to describe the mechanical properties that are useful for understanding both patient physiology and patient-ventilator interactions. There are two basic mechanical properties of interest for understanding mechanical ventilation. The first is resistance, defined as the ratio of pressure change to flow change. The second is elastance, defined as the ratio of pressure change to volume change. Compliance, defined as the reciprocal of elastance, is often used instead of elastance. You need to memorize the simple equations for resistance, elastance, and compliance. Note that this model can take several forms. It can be graphical, like the drawing in this slide. It can be physical, like an actual tube attached to an elastic container, the classic straw and balloon model. Or it can be mathematical, that is, expressed in terms of pressure, volume, and flow as functions of time. The most useful form of the single compartment model of the respiratory system is the mathematical form. This form is called the equation of motion for the respiratory system. It is the single most important concept if you want to understand patient-ventilator interaction. Newton's third law of motion states that for every action, there is an equal and opposite reaction. That is, the pressure the ventilator exerts on the patient to generate inspiration is resisted by an equal and opposite pressure generated by the patient. Note, all pressures are measured relative to baseline or PEEP. Next, we can expand the right-hand side of the equation to show that the reaction of the respiratory system has two components. One is called the elastic load, and the other is called the resistive load. The elastic load is the pressure equal to elastance times volume, or volume divided by compliance. The resistive load is the pressure equal to resistance times flow. Note that pressure, volume, and flow are continuous functions of time. Elastance and resistance are constants. If the patient is breathing along with the ventilator, both combine to generate the pressure required to overcome the elastic and resistive loads. The pressure generated by the patient's ventilatory muscles is called P-mus. The pressure generated by the ventilator is called P-vent. That is enough theory to start the topic of mode taxonomy or classification system. The need for a taxonomy of modes has evolved rapidly along with the increase in ventilator technology complexity. There are now over 500 different brand names for modes created by ventilator manufacturers, and yet there is only a few dozen modes that are actually unique, and many of these modes are not mentioned in the operator manuals. With the proliferation of brand names for modes, we need a taxonomy to create generic mode classifications for the same reasons we need generic drug names. Our aim is to improve communication amongst clinicians, educators, researchers, and manufacturers. This will allow us to better understand and use the available technology to ultimately improve patient care. In addition, a taxonomy is important for ordering modes and charting patient outcomes. Again, the precedent is ordering and charting drugs. Quality improvement through data mining of electronic medical records is severely hampered when random terms are used for modes. We currently have a manuscript in review on this topic. Let's define some key words. First, as I said, a taxonomy is a classification system that is used to distinguish between the same and different modes independent of the names ventilator manufacturers have coined. A tag is a set of letters that represents the mode classification. It includes the control variable, the breath sequence, and the targeting schemes. The breath control variable is the variable in the equation of motion, either pressure or volume, that is predetermined by ventilator settings, independent of lung mechanics. The breath sequence is the pattern of mandatory and spontaneous breaths that comprise a mode of ventilation. The targeting scheme is the feedback control algorithm used by the ventilator to achieve the preset targets of the mode. A target is any parameter set by you or the ventilator as a desired output. Inspiratory pressure in pressure control modes is one example. Tidal volume and inspiratory flow in volume control is another example. A target can be just about anything that can be measured as a desired output of mechanical ventilation. The start of inspiration is called the trigger event and can be due to either the patient or the machine. The end of inspiration is called the cycle event and can be due to either the patient or the machine. Among the most important definitions are those for spontaneous and mandatory breaths. These terms are very much misunderstood in the literature, but are key to understanding the mode taxonomy. A spontaneous breath is one for which the patient retains substantial control of the timing of the breath. This means that inspiration is both triggered, started, and cycled, stopped, by the patient, independent of any setting for inspiratory time on the ventilator. In contrast, a mandatory breath is one for which the patient has lost some or all control over timing. This means inspiration is either triggered or cycled by the machine. The taxonomy specifies that there are three components of a mode. These are the control variable, the breath sequence, and the targeting scheme. Together they combine to form an abbreviation or tag representing the generic classification of the mode. Any mode, past, present, or future, can be classified in this manner. The mechanical ventilator can only control one variable at a time, either pressure or volume. This refers to the inspiratory phase. Actually, in volume control, the ventilator is controlling flow, but by historical convention, it is called volume control. The equation of motion is the theoretical basis for defining pressure control and volume control modes of mechanical ventilation. The ventilator can only control one side of the equation at a time. Pressure control means that the ventilator is controlling the left-hand side of the equation. That is, pressure is either maintained at a constant target value or it is automatically adjusted to be proportional to the patient's inspiratory effort. Changes in elastance and resistance cause changes in volume and flow. As the operator, you either set the inspiratory target pressure or the constant of proportionality between P-vent and P-mus. Volume control means that the ventilator controls the right-hand side of the equation. This means that both tidal volume and peak inspiratory flow are preset. Changes in elastance and resistance cause changes in pressure. Here are three representations of the ideal waveforms for volume control and pressure control. For volume control, the flow waveform is preset, usually as a square or descending ramp shape, but other possibilities exist. In pressure control, if the pressure waveform is preset, it is usually a square, but again, other possibilities exist. If P-vent is proportional to P-mus, then the pressure waveform can have a wide variety of random shapes. Given that there are only two breath types, that is, spontaneous and mandatory, there are only three possible breath sequences. One sequence is all mandatory breaths, called continuous mandatory ventilation, or CMV. In contrast, there could be all spontaneous breaths, called continuous spontaneous ventilation, or CSV. If spontaneous breaths may occur between mandatory breaths, we call the sequence intermittent mandatory ventilation, IMV. IMV Type 1 is the legacy form in which mandatory breaths are delivered at the set rate, no matter what the patient wants. IMV Type 2 allows the patient to suppress mandatory breaths, which are less comfortable, by simply triggering spontaneous breaths at a higher rate than the set mandatory breath rate. The problem with IMV Type 2 is that mandatory breaths may be suppressed by a rapid, shallow breathing pattern that could lead the patient to hypoventilate. Therefore, IMV Type 3 allows the patient to suppress mandatory breaths only when the minute ventilation due to spontaneous breaths is higher than the target minute ventilation from mandatory breaths. Finally, IMV Type 4 allows the patient to turn a volume-controlled mandatory breath into a spontaneous pressure support breath if the inspiratory effort is large enough. This, in effect, allows the patient to override the settings for tidal volume and peak inspiratory flow in the service of comfort and synchrony. For example, such a breath sequence can prevent double triggering that could lead to serious tidal volume overdose in regular volume control modes with set point targeting. The fact that there are two control variables and three breath sequences allows us to categorize all modes into one of five groups: volume-controlled CMV, volume-controlled IMV, pressure-controlled CMV, pressure-controlled IMV, and pressure-controlled CSV. You will note that volume-controlled CSV is not a possibility because volume control implies machine cycling of inspiration, which by definition results in a mandatory breath, not a spontaneous breath. Targeting scheme is the software programming the ventilator uses to achieve the desired targets. Targeting schemes have evolved from simple ones that require manual adjustment to complicated ones that have various degrees of automation. At the present time, there are 7 targeting schemes used to create dozens of different modes. Sometimes multiple targeting schemes are used in a single mode. We will now review some very brief definitions of targeting schemes. You will have to memorize these definitions if you want to fully understand and use the taxonomy. Setpoint targeting, abbreviated with a lowercase s, means that all targets are operator preset. Dual targeting means the ventilator can automatically switch between volume control and pressure control within a single breath. Biovariable means that the ventilator randomly changes the inspiratory pressure and hence tidal volume to mimic normal breathing. Servo targeting means that inspiratory pressure is automatically adjusted to be proportional to inspiratory effort. In effect, P-vent is used to amplify P-mus, similar to the way power steering works in a car. Adaptive targeting means that the ventilator automatically adjusts the inspiratory pressure as lung mechanics change to achieve an average tidal volume equal to the preset target. This means, for example, that inspiratory pressure decreases as compliance increases or inspiratory effort increases. Optimal targeting means that the ventilator uses adaptive targeting to select both an inspiratory pressure and frequency for mandatory breaths that minimizes the power transfer from the ventilator to the respiratory system. Optimal targeting is in fact the way the brain controls the ventilatory pattern to minimize caloric expenditure during normal breathing. Recent research suggests that minimizing power transfer may decrease the risk of ventilator-induced lung injury. Intelligent targeting schemes use the tools of artificial intelligence, such as mathematical models, fuzzy logic, rule-based expert systems, and artificial neural networks. The most advanced form of this scheme is called IntelliVent and can automatically select tidal volume, frequency, PEEP, and FiO2 while enforcing rules for lung protective ventilation. The tag is the way to summarize the components of a mode. Notice that when there is an IMV mode, there are at least two targeting schemes indicated. The first one is the targeting scheme for the mandatory breaths. The second one is for the spontaneous breaths. Some modes have multiple targeting schemes for both kinds of breaths. Now that we know how to identify modes, the next step is to understand how to select the right mode at the right time. The first step is to understand that while there are any number of indications for mechanical ventilation, there are only three basic goals. The first goal is safety, meaning that we must ensure adequate gas exchange, and we must do this with a lung protective ventilatory strategy that minimizes the risk of ventilator-induced lung injury. The second goal is comfort. This means that we should try to maximize patient-ventilator synchrony. But it also means that we should minimize work shifting from the ventilator to the patient. We will say more about this new concept shortly. Finally, from the moment we start mechanical ventilation, we should be thinking of how to remove it. We want to minimize the duration of ventilation and avoid adverse events. The important thing about these goals is that only one should be considered the most important at any point in time. Normally, safety is the most important at the start of ventilation. But as the patient's condition stabilizes and breathing efforts appear, comfort becomes more important. Finally, at some point, liberation from the ventilator becomes of paramount importance, and we may test the patient with a spontaneous breathing trial. If we can identify the primary goal of ventilation, then we can more easily select the most appropriate mode. That mode will be the one with the most robust technical capabilities for serving that goal. Modes without these capabilities are less appropriate or even inappropriate. This kind of reasoning is no different from selecting the most appropriate drug for a patient. We would not think of selecting a drug simply because we are familiar with it, independent of the patient's needs, and we should not select a mode of ventilation that way either. Let's see how this reasoning can be applied at the bedside. Suppose the goal is safety. Our clinical objectives are to provide adequate gas exchange while protecting the lungs. The technical capabilities we want in a mode are, at the very least, the ability to manually adjust the minute ventilation independent of changes in lung mechanics, and this suggests some form of volume control. An alternative would be pressure control with adaptive targeting, which again allows setting of both mandatory rate and tidal volume dosage. Based on this reasoning, we select modes with the desired technical capabilities and which are readily available. It should be no surprise that the most common mode in the world is volume control continuous mandatory ventilation, popularly known as volume assist control. But pressure control modes with adaptive targeting, such as the mode called pressure regulated volume control, are gaining popularity, especially for ventilating neonates. After the patient has stabilized, the goal may shift to comfort. Now our clinical objectives include the desire to maximize patient-ventilator synchrony. Perhaps the most important feature of a desirable mode would be the ability for spontaneous breaths, as the patient retains control over timing and synchrony is improved and comfort supported. Furthermore, the mode should be some form of pressure control so that we do not impose an arbitrary flow pattern on the patient. Finally, if the patient's ventilatory drive is reliable, the mode should not impose mandatory breaths, but they should be readily available in the background without triggering alarms if apnea occurs. This reasoning leads us to select a simple mode like pressure support, especially if the patient's ventilatory demand is reliable and the projected duration of ventilation is relatively short. If the patient's drive to breathe is unreliable but mostly present, then the best mode would be some form of pressure control with IMV type 2. An even more robust mode would be something like auto mode with PRVC for mandatory breaths and volume support for spontaneous breaths, because we would also be serving the goal of safety. But suppose our desire to serve the goal of comfort was focused mainly on adequate support for the work of breathing. Let's say the patient had a varying inspiratory effort and we found that adaptive targeting led to unstable blood gases and patient discomfort. Or it might be the case that there is a problem with failed trigger efforts, as often happens with severe COPD and gas trapping, where patients miss breaths and become anxious. In this case, we might prefer a mode that can provide inspiratory support in proportion to the patient's inspiratory effort. The only modes that can provide these capabilities are ones that provide pressure-controlled continuous spontaneous ventilation with servo targeting, proportional assist ventilation, PAV, or neurally adjusted ventilatory assist, NAVA, are examples. NAVA in particular is a remedy for failed trigger efforts. Sooner or later, the goal becomes liberation from the ventilator. The main objective is to minimize the duration of mechanical ventilation. Unfortunately, there are a few technical features on modes today that serve this goal with little scientific evidence of effectiveness. What we would like is some form of automatic reduction of support as the patient's condition improves. It would also be convenient if a spontaneous breathing trial could automatically be initiated once the support had been reduced enough. These features would free the patient from dependence on periodic manual adjustments that generally prolong the duration of ventilation for purely practical reasons. Finally, automatic interpretation of SBT results could speed extubation. In the right context, a mode like pressure control with adaptive targeting could reduce P-vent as P-mus naturally increased. This would be appropriate in a scenario like awakening from anesthesia for a patient with normal lungs. For patients that require more long-term ventilation with perhaps the ability to tolerate brief setbacks or resting at night, a mode like SmartCare could be ideal. It uses a rule-based expert system to manage pressure support to keep the patient comfortable, wean pressure automatically, and even perform a spontaneous breathing trial. Using the simplest modes that are commonly available, we could serve the goals of ventilation as follows. The goal of safety can be served with volume control CMV, provided there was little or no inspiratory effort, and hence the specific values for inspiratory time and flow are irrelevant. The goal of comfort could be served with pressure control IMV type 1, but with strict attention to reduction of the mandatory breath rate as the spontaneous breath rate becomes reliable. Finally, liberation is served with pressure support with strict attention to reduction of inspiratory pressure as patient strength improves. Pressure support is often also used for spontaneous breathing trials. This is a portion of a pocket card we give to students that helps to summarize the ideas we have just covered. Clinical objectives are color-coded, red for safety, green for comfort, blue for liberation. The table shows mode categories that use only mandatory breaths, CMV, or only spontaneous breaths, CSV. Reading across the rows, the clinical objectives determine the appropriateness of the potential mode selections. The green shading indicates modes that serve the objective and are recommended. The yellow shading indicates modes that only partially serve the objective and should be used with caution. The red shading indicates that the mode has no features to specifically serve the objective. The card also has a table that includes IMV type modes. It does not distinguish between the 4 different types of IMV for simplicity, but you should know that types 2 and 3 are generally better than type 1 in this regard. Now that we know how to identify and select the appropriate mode, we'll move on to monitoring the patient-ventilator interaction using waveform analysis. Needless to say, this is a complicated topic, and we can give only a brief overview in this lecture. Waveform analysis rests on a firm understanding of some basic terminology. Most confusing is the terminology around pressures and pressure differences. I hope you will take the time to study this slide at your leisure. Total PEEP is end expiratory pressure above atmospheric pressure. Auto PEEP is end expiratory pressure above the set PEEP. Plateau pressure is end inspiratory pressure above atmospheric pressure. Tidal pressure, often called driving pressure, is end inspiratory pressure above total PEEP. Work shifting means that the work of breathing is shifted from the ventilator to the patient anytime the patient makes inspiratory efforts. From the equation of motion, this means work shifts anytime P-mus is greater than 0. As long as P-vent is greater than 0, that is, airway pressure is greater than PEEP, some work of breathing is supported by the ventilator. In volume control, as P-mus increases, P-vent decreases, but this effect may be clinically acceptable and indeed unavoidable if the patient is to trigger inspiration. However, if P-mus is so great that the airway pressure drops below the set PEEP, then severe work shifting is occurring. This should be treated by first determining the cause of the increased ventilatory drive. If this cannot be addressed clinically, no mode or mode setting can fix it. Patient-ventilator synchrony means that the ventilator delivers flow when the patient demands it. In terms of the equation of motion, it means that P-vent starts and stops at the same time as P-mus. P-mus, or patient effort, is the reference signal. While P-mus is seldom actually measured, various signals are used as surrogates, including esophageal pressure and the EDI signal from a NAVA catheter. Synchrony means that one of the two signals, P-mus or P-vent, is missing. For example, a failed trigger effort means that there is a P-mus signal without a corresponding P-vent signal. On the other hand, a false trigger means there is a P-vent signal without a corresponding P-mus signal. Dysynchrony means that the two signals exist, but they are out of phase. This means that their start and stop points do not match. For example, early trigger or cycle means that P-vent occurs before P-mus. On the other hand, late trigger or cycle means that P-vent occurs after P-mus. The ventilator supports the work of breathing by delivering volume under pressure. Work shifting means that some portion of the work of breathing moves from the ventilator to the patient due to patient inspiratory effort. Work shifting is shown graphically in this slide as P-vent decreasing as P-mus increases, as happens in volume control modes or pressure control modes with adaptive targeting. The total work stays the same, but the portion done by the patient increases with P-mus. In contrast, pressure control modes with set point targeting keep P-vent constant as P-mus increases. In this case, the total work increases because the tidal volume increases and the patient performs a larger portion. The only way to avoid work shifting is to use a mode that increases P-vent in proportion to P-mus, as is the case with pressure control with servo targeting. In this case, the tidal volume and work per breath is free to vary, but the proportion of work done by the patient remains relatively constant. A key concept in the understanding of ventilator waveforms is the idea of a time constant. The time constant is a characteristic of exponential curves as seen in inspiratory volume and flow waveforms during pressure control. The time constant is calculated by multiplying resistance by compliance, with the resulting units of time, usually seconds. In a unit of time equal to one time constant, an exponential curve will change by 63%. This is important for determining whether volume and flow curves represent normal or abnormal respiratory system mechanics. A long time constant usually means an increased resistance. A short time constant usually means a decreased compliance. Now let's take these basic concepts and apply them to bedside ventilator waveform interpretation. We will use a four-step approach. The first step is to identify the tag of the mode we are observing, or its classification. Believe it or not, you can usually deduce the mode just by looking at the waveform. Here we see a checklist of the most commonly used mode tags. You can appreciate that in a department that uses several different ventilators, and with each ventilator having between 10 and actually 75 different modes, the use of mode names for this purpose would be impractical. The first step in identifying the mode is to memorize the shapes of the basic pressure, volume, and flow waveforms for volume control and pressure control. Note that the shape of the pressure waveforms reflects the elastic and resistive loads according to the equation of motion. We will say more about identifying the breath sequence and targeting schemes later. The second step is to define the load that is being reflected in the waveforms. As we have mentioned several times, there are two basic loads according to the equation of motion, the elastic load and the resistive load. In the context of waveform distortion, P-mus can also be considered a load. We can see the effects of loads during both inspiration and expiration. During volume control, with a constant flow, increased elastic or resistive loads increase airway pressure as shown here. Elastic load changes the slope of the pressure time waveform. Resistive load changes the height of the pressure time waveform uniformly. During volume control with a ramp flow, if flow goes to zero at end inspiration, the effects of elastic and resistive loads are separated. At the end of inspiration, there is volume but no flow, so the height of the pressure waveform reflects only the elastic load. Indeed, end inspiratory pressure can give you an estimate of plateau pressure without having to use an inspiratory hold. At the start of inspiration, there is flow but no volume, so the height of the pressure waveform reflects only the resistive load. For pressure control with a square pressure waveform, increased elastic and resistive loads decrease the tidal volume. For volume control, inspiratory effort will deform the pressure waveform downward towards the baseline. For pressure control, inspiratory effort will deform the volume and flow waveforms upward, away from baseline. The important thing to remember is that when there is a large P-mus, it may be impossible to detect the effects of changes in compliance and resistance. Step 3 is to identify the pattern of patient-ventilator interaction. This step is divided into the 4 phases of a breath: trigger, inspiration, cycle, and expiration. Normal triggering means that inspiratory flow delivery occurs at an acceptable delay relative to the patient effort. Late triggering means that flow delivery occurs after a substantial delay relative to the inspiratory effort. Early triggering is identified when the breath is machine triggered and is followed by an inspiratory effort. We say it is early triggering because the machine trigger signal occurs before the patient trigger signal. In the literature, this is often called reverse triggering, meaning that the machine triggered the patient to make an inspiratory effort instead of the other way around. This condition is thought to be associated with toxicity due to excessive sedation. In false triggering, there are apparently patient-triggered breaths. However, there is no evidence of P-mus, and we see no expiratory flow, signaling the presence of a large leak. In the case of a failed trigger effort, P-mus is not large enough to get flow to cross zero from negative flow to positive flow. As a result, the ventilator is unaware of the effort, and note that adjusting the trigger sensitivity is useless because it depends on a positive flow signal. Continuing with step 3, we next examine the inspiratory portion of the pressure, volume, and flow waveforms. During volume control, an increase in P-mus causes a decrease in P-vent, according to the equation of motion. Because work assistance is proportional to both pressure and volume, a decreased P-vent means decreased work output of the ventilator. Hence, work has shifted from the vent to the patient. In extreme cases, such as the second breath, the airway pressure dips below the set pressure. This is clinically unacceptable, indicating severe discomfort in a conscious patient and would lead to diaphragm damage or pulmonary edema. During pressure control, an increase in P-mus causes an increase in both the volume and flow waveforms, again according to the equation of motion. Work is shifted to the patient as tidal volume increases. In this slide, the first breath is passive, the second breath shows some inspiratory work, and the third breath shows extreme work shifting. The third phase of the breath is the cycle phase. As with triggering, this phase can be normal, early, or late. This slide illustrates a pressure control breath with just enough P-mus to trigger it. Inspiration proceeds passively and cycles off without incident. Here we see a pressure-controlled breath with a large inspiratory effort, as indicated by the distorted flow waveform. Note that the flow returns to zero before the end of the preset inspiratory time, as indicated by the two vertical dotted lines. Notice also that the large effort decreased the rise time of the airway pressure at first, and then, when PMUS relaxed, pressure rose suddenly to the largest level. This pattern indicates late cycling because the preset inspiratory time was longer than the patient's neural inspiratory time. In this slide, we again see a pressure-controlled breath with a large inspiratory effort indicated by the distorted flow waveform. But in this case, the effort extended beyond the preset inspiratory time, distorting the peak value of the expiratory flow waveform. We call this early cycling because the preset inspiratory time was shorter than the patient's neural inspiratory time. The final part of step 3 is to examine the expiratory portion of the waveform. In this slide, the yellow dashed line shows the expected passive exponential decay of the expiratory flow waveform under normal conditions. In the second panel, the expiratory flow waveform is distorted in the negative direction, indicating that PMUS is generating more expiratory flow and hence shows the patient doing expiratory work. Finally, having assessed the important aspects of patient-ventilator interaction, the fourth step is to give recommendations for intervention. These recommendations must be based on your assessment of the primary goal at the point in time. Is it safety, comfort, or liberation? The first option is to adjust the ventilator settings in the current mode. The second option is to change the mode. The third option is that no intervention is indicated. And the fourth option is to recommend some non-ventilator intervention, like perhaps increasing or decreasing sedation. In the next few slides, we will use this procedure to evaluate a waveform taken from an actual patient. The first step is to identify the mode. We observe that inspiration starts out at a constant flow, which indicates volume control. We also see a consistent tidal volume and inspiratory time for each breath, which suggests machine cycling, and hence the breath sequence is CMV. As for the targeting scheme, note the distortion in the flow waveform at the same time as the distortion in the pressure waveform. This pattern indicates a large inspiratory effort that signals the ventilator to momentarily increase flow, characteristic of dual targeting. Now we deduce the load. To determine the load, we look first at the flow waveform and then the pressure waveform. As in the last slide, we note the increase in flow and the decrease in pressure, which are both caused by an increase in inspiratory effort. Therefore, we conclude that the load is PMUS. Remember that when PMUS is this large, it may be impossible to determine the effects of changes in compliance and resistance. However, we can look at the expiratory flow waveform and see that the time constant looks normal, so we conclude normal lung mechanics. Now the fun part. How would you characterize the patient-ventilator interaction status? First, we conclude that there seems to be normal flow triggering as indicated on this ventilator by the white portion of the green flow waveform. Second, we would again note the inspiratory work shifting, and in fact, because the airway pressure falls below PEEP, we could call this flow starvation, indicating that at some point, the flow demanded by the patient exceeded the flow from the ventilator. But as long as the pressure remains at or above PEEP, then the ventilator meets or exceeds the patient's flow demand. Looking at the end of inspiration, it appears that the relaxing of PMUS, as reflected in the distorted flow waveform, happens to correspond with the end of the preset inspiratory time. Also, there is no distortion of the peak expiratory flow, indicating that the inspiratory effort has ceased. We conclude that cycling is normal, neither early nor late, which is rare for a mandatory breath. Looking at the expiratory flow curve, we see no indication of PMUS and indeed what looks like a normal time constant.
This concludes the Seva Crash Course. We hope that you have come to appreciate the importance of understanding the equation of motion as the theoretical basis of mechanical ventilation.
Perhaps more importantly, you now realize how useful a taxonomy can be for understanding modes of ventilation as well as patient-ventilator interactions. I thank you for your attention. Please feel free to contact me for more information.
Finally, I hope you see that interpreting ventilator waveforms is just as important a skill as interpreting ECG waveforms. It helps us ensure the patient's needs are being met. One of the best ways to practice your new skills is by using this simulator, available free from Hamilton Medical. This simulator not only allows you to use most of the modes on a C6 ventilator, including ASV, but it also simulates the physiologic response to ventilator settings like SpO2 and tidal CO2 and simulated blood gases. It also has the unique ability to realistically simulate the response to a recruitment maneuver. I can think of no better way to learn mechanical ventilation without needing a lab or risking patient safety. As another way to practice your new skills, we invite you to join us every other week online for Seva Vent Rounds. Here we review actual ventilator waveforms taken from patient cases using the Seva method. Please contact us if you are interested in any of the other courses that are part of the Seva program. I thank you for your attention.